students, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. I am Dr. Ramyasree. In this video, I'm going to tell you what are the other updates we have in the Williams. First and foremost, as I already stated, not to worry, there's not much major changes or something to panic. Minor changes, you just write these into your notes. Khatam baat. So first, I'll tell you the updates from chapter of miscarriage. We're not supposed to call it as abortion anymore, but yes, I've written here abortion. Now we call it as miscarriage. So the definition of inevitable abortion has been changed. Earlier we used to tell inevitable abortion is the process of abortion has gone to that state where it cannot revert back to normal. But according to the new Williams, inevitable abortion is, so inevitable miscarriage. Inevitable miscarriage is, so here the process of miscarriage has gone to that state where it cannot revert back is the old definition. According to the new definition, what it tells is, consider this as early PPROM, preterm premature rupture of membranes, and treat as early PPROM. So once there is an inevitable abortion, miscarriage where os is open or membranes got ruptured, wait for 24 hours for spontaneous expulsion. Wait for 24 hours for spontaneous expulsion. So if it gets expulsed and if it goes into incomplete abortion, then you terminate. You can't do anything there. But after 24 hours also, if it didn't get expelled, so if it remains same, then continue the pregnancy and treat it as early PPROM. So you have to give her bed rest, antibiotics. If the amniotic fluid has gone out too much, you can plan amnio infusion. So you have to keep monitoring her and try to pull her till 34 weeks. Any times before, if there is chorioamniotis, you might require to terminate. But what I'm trying to say here is, in inevitable miscarriage, according to the new concept, no need to terminate that pregnancy. Wait for 24 hours. If it gets terminated, don't stop. But after 24 hours also, if it remains and heartbeat is still present, no infection has occurred, then continue it as early PPROM and pull that pregnancy as an early PPROM. So this is the new concept. I hope all of you are clear with this concept, right? Coming to the next change. So we all know what is missed miscarriage. Dead fetus lying inside the uterus is a missed miscarriage, right? So missed miscarriage sonographic findings also has changed. So missed miscarriage is when crown rump length is more than or equal to 7 mm and no heartbeat. Mean sac diameter more than 25 mm with no embryo. This is called missed miscarriage according to the old definition. So that is the dead fetus lying inside the uterus. So when crown rump length, head to toe, or the crown to the rump of the baby is more than 7 mm but no FHR, or when mean sac diameter, when you take it from here to here, so mean sac diameter more than or equal to 25 mm with no embryo, you call it as missed miscarriage, right? Now the second new definition which has come is, when an initial ultrasound scan shows sac with yolk sac, so if your initial scan is showing sac with yolk sac, and after 11 days, also if there is no embryo with a heartbeat, then you call it as a missed miscarriage. So what is missed miscarriage? New definition. So when you have done an initial ultrasound where you have seen a sac with a yolk sac, and when you have repeated it after 11 days, but you have not seen any embryo with a heartbeat, then you can call it as a missed miscarriage. Second definition, or the last definition which has been included now new, is when you have done an initial scan with a gestation, where you have seen a gestational sac but there is no yolk sac, you repeat the scan after 2 weeks. And if you still don't see embryo or a heartbeat, then you can call it as a missed miscarriage. So these two are additional definitions, ultrasonic findings in the missed miscarriage in the new Williams. Easy hai. So I repeat, sac with yolk sac hai, to repeat the scan after 11 days. If still heartbeat has not come, it's a missed miscarriage. Sac without a yolk sac, repeat the scan after 14 days. If still heartbeat has not come, then you can call it as a missed miscarriage. Okay? Next, whenever you see the finding of missed miscarriage, don't jump and go and terminate it. You can wait for 1 week for spontaneous expulsion. As a benefit of doubt, you can wait for another 1 week. This is according to the NICE guidelines. So even after 1 week also, if the findings persist, then you can go for termination. That is second point which you should know. Okay? Clear? These are the two things I found from the miscarriage, the definitions of the miscarriage. These are the two things which I felt that new and you all should know. Next, coming to the methods of termination. So methods of termination medical methods there are certain changes or there are certain points which you should know. So in the medical methods, so if you take first trimester, so first trimester mifepristone bar misoprostol. So you can give day 1 mifepristone 200 milligrams orally and after 24 hours. So earlier this mifi and miso regimen it was after 48 hours, right? So now in this Williams what he tells, after 24 hours you provide misoprostol 800 micrograms. So you provide misoprostol 800 micrograms. You can either provide it as per vaginal, sublingual or buccal route, but don't give it as oral. Oral is less efficacious. So this is a change, that is after 24 hours you provide misoprostol. Second regimen which is highly efficacious, as efficacious as mifi and miso is, you can give 800 micrograms alone and you have to repeat it every 3 hours and you give it for total 3 doses. This is the second regimen. So 800 micrograms alone, you can repeat it every 3 hours, maximum total 3 doses. Okay? So this is the mifi and misoprostol ka regimen 1 and misoprostol alone regimen. Now coming to the second trimester regimen. So second trimester again he has given mifi and miso regimen. So mifepristone 200 milligrams per oral and after 24 hours you can give misoprostol 400 micrograms every 3 hours up to 5 total doses. So instead of giving misoprostol 800, you can just give 400 micrograms every 3 hours, maximum of 5 doses. Okay? So mifepristone 200 milligrams per oral and after 24 hours you can give misoprostol 400 micrograms every 3 hours, maximum of 5 doses. So that is the second regimen we have for second trimester which you have to learn. So this entire table I feel you should jot down because I didn't teach this previously. So this is new to our notes. So please jot down this methods of termination. Okay? Next, you can give misoprostol alone also. So misoprostol 400 micrograms every 3 hours up to 5 total doses. So basically what is happening, if you see the dose from first trimester to second trimester, dose of the misoprostol has almost become half. Is there any logic or just like that? Previously I used to get very irritated why they have changed, once 800, once 400, third trimester 100 or 50. Why is this so much change of misoprostol dose? When you understand the reason for it, you feel okay, that's logical and definitely this should happen. When you take the number of receptors of misoprostol or of prostaglandins on the uterus in the first trimester, they're very less. And indeed, you don't give oxytocin in the first trimester because you don't have any receptors for the oxytocin in the first trimester. When you compare the uterus in the second trimester, the number of receptors for prostaglandins have increased and the receptors for oxytocin also start coming on the uterus in the second trimester. So that is why you can use prostaglandins at a less dose in the second trimester. And that is why in the third trimester, the dose of misoprostol further drops down because number of receptors increase. Beautiful. And oxytocin also we give it only from second trimester because receptors are found only after second trimester. Understood why the dose difference? Third trimester where the receptors have further increased. That is why third trimester when you're using misoprostol for induction of labor, you can give only 50 to 100 micrograms. Enough, right? So you can also give dinoprostol in the second trimester, which is a 20 milligrams vaginal suppository. You can keep it every 4 hours. Second trimester medical methods you can also give concentrated oxytocin, 50 units of oxytocin in 500 ml of normal saline. You infuse for 3 hours. 1 hour you should leave it. 1 hour nothing should be done for the diuresis to happen. Then if bacha didn't come out, you escalate the dose of 50 units to 150. Then you escalate it to 200, then 250, then 300, like that. Okay. So this is regarding the three changes which I have seen in the new Williams. So one is the concept of inevitable abortion, you should know, which is changed. Second, missed miscarriage, also you should know. Third, methods of termination, also you should know. So these are the three changes which we have in the abortion chapter or miscarriage chapter. Next, coming to the diabetes chapter. Diabetes chapter, I felt there are some new aspects or new points given, and I liked them actually, to be frank. I felt it was more organized way of presentation in the Williams. Previously, I used to not like so much diabetes chapter so much, and I used to read Gabe and all. But I felt I liked this diabetes chapter now from the Williams, so I'll present it to you. So we all know, I'm not going to what you already know. These videos are to be watched additional to what you have learned. This is not replacing any topic, guys, because here I am just telling you what are the new points you have to incorporate into your notes. I am not telling you full topic. Ye dhyan mein rakho. Then don't think that this much if you read it's enough for diabetes or abortion. No. Okay. So coming to the diabetes, we all know that we have two types of diabetes, that is overt diabetes and gestational diabetes. So first we'll discuss about overt diabetes. So overt diabetes is glucose intolerance for the first time in pregnancy. So whenever you have overt diabetes, so in the neonate or the baby which is born, all diabetes babies are not macrosomic. In overt diabetes, in the neonate, you can see IgR in the baby if there is vasculopathy. So in overt diabetes management, preconceptional care mein HbA1c should be less than 6.5. Folic acid, our traditional learning is 5 milligrams 3 months prior, but according to New Williams, you have to give folic acid of 400 micrograms per day from 3 months prior. So it is the prophylactic dosage which he has given. Anyway, I'm telling you what is written in Williams. So according to the New Williams, folic acid is only 400 micrograms per day preconceptionally when you are giving. But in India, let me tell you guys, we give everyone 5 milligrams, therapeutic, prophylactic, sabko 5 milligrams because we are deficient in folic acid. Anyway, as per Williams, folic acid preconceptionally is 400 micrograms per day and HbA1c should be maintained less than 6.5. Now coming to the antenatal management, he mentions that in the first trimester, do the aneuploidy screening because they're prone for many anomalies. Do the aneuploidy screening. So you do double marker plus NT scan. In the first trimester, this is the best screening method. And he clearly gives that insulin is the drug of choice. Insulin is the drug of choice. Not only for overt diabetes, even for gestational diabetes patient, he clearly gives that insulin should be the drug of choice and insulin is preferred compared to the OHAs like metformin. So we always prefer in insulin mixture, which is a combination of regular insulin and isophane insulin, which can come, you can give it as 70-30 or 50-50. And after that, monitoring these patients, you can check the capillary glucose levels with glucometer. So according to American Diabetes Association, he tells that you have to monitor with FBS, PPBS, but it's acceptable even if you check with glucometer. So fasting should be maintained less than 95. Pre-meal should be less than 100. 1 hour postprandial less than 140. 2 hours postprandial less than 120. 2 to 6 a.m. it should be more than 60 because 2 to 6 a.m. we tend to go into hypoglycemic episodes. And HbA1c should be maintained less than 6%. On an average, blood glucose should be in a range of 100 always. Okay? So dietary composition for overt diabetes patient, 55% they should contain carbohydrates, 20% proteins, 25% fats with 10% less than, and their food should contain less than 10% saturated fats. Next, so this is all in the first trimester. Very beautiful, no? I really like the organization. Yeah, this is notes made by me, the way it is organized. But yes, Williams also is somewhat telling like this. So we discussed preconceptionally. Next, antenatal mein first trimester, what you are doing. Now coming to the second trimester. Again, we know that these babies are prone for anomalies. So, and they are prone for neural tube defects. So, maternal serum alpha fetoprotein at 16 to 20 weeks of gestation. Targeted USG or TIFA scan at 18 to 22 weeks of gestation. And you are supposed to do fetal echo at 18 to 20 weeks of gestation. Okay. This is not changed. Third trimester care में fetal monitoring should start from 32 to 34 weeks. You do daily fetal movement count and NST you can do weekly. Over DM well controlled on medication, deliver them by 39 to 39 plus 6 weeks. Now this is not something new but same like previous. So when you're managing the insulin dose during delivery, evening dose of insulin to be given, withhold the morning dose. You can start them on infusion of normal saline 100 to 125 ml per hour. So basic funda is that the blood glucose level of this patient during labor should be maintained between 70 to 100 milligram per deciliter. If it goes less than 70, what are you going to do? Change the normal saline to 5% dextrose. And if it is going more than 100 milligram per deciliter, then you have to start her on regular insulin IV, regular insulin infusion of 1.125 international units per hour. And you have to measure the glucose levels every hour. This is the management during labor. Puerperium mein first post delivery first 24 hours you don't require any insulin, and shift from insulin to OHA on day 1 postpartum. So when the day of operation or day of delivery is day 0, no, next day say you can shift her to OHS. Contraceptive of choice is IUCD. So that is regarding the over DM, a very organized and a beautiful presentation I felt from the Williams. So that you just jot down. I think diabetes ka one chapter management ka you can cross the previous one and write this one. So gestational diabetes mellitus, you have to screen first visit and repeat the screening at 24 to 28. There's no change in the screening method, so I'm going to skip with the screening methods. This is the same which we have learned previously. Now coming to the management. So management also the same, that is first start them on medical nutrition therapy with diet and isometric exercise. Give her 3 major and 3 minor meals. According to ACOG 2019, these patients ka diet is little changed. See, compared to over DM, GDM ka diet also is little different. This is new, which we didn't have in the previous Williams. So the diet should contain 33 to 40% of carbs, 20% proteins and 40% fats. Yes, write down the same. After 2 weeks, when you do the scan, when you do FBS should be less than 95, PPBS 2 hours should be less than 120. If uncontrolled, start them on insulin. So here very clearly they have mentioned that drug of choice on the first line even for GDM is insulin. OHS can be used, but they wrote it has some side effects and also better to avoid करके ही लिखा था. So remember, insulin is the drug of choice for both overt as well as GDM. ठीक है? So GDM well controlled on diet 40 to 40 plus 6 weeks of gestation. GDM well controlled on medication, give 39, you deliver them by 39 to 39 plus 6. GDM or over DM poorly controlled, you deliver them by 37 weeks. GDM or over DM uncontrolled, you deliver them by 34 weeks of gestation. Okay. So mode of delivery according to ACOG, birth weight should be more than 4.5 kgs. Then we go for elective LSCS. If birth weight is more than 4 kgs, elective LSCS according to ACOG. But American College. In India, birth weight is more than 4 kgs also you have to go for LSCS. So for us, cutoff for LSCS is 4. For Americans, it is 4.5. Less than 4 kgs, you will go for vaginal delivery, guys. Less than 4 kgs, you can go for vaginal delivery. So those are the small updates. Do you think there are some major changes? I told you, no, there are very minor changes. Don't be scared or don't be worried. Hannah. So these are the small changes which we have in the diabetes. Incorporate into your books. Not a major change. Now coming to the hypertension. So hypertension mein already there were so many updates and I think we all already wrote the updates. So I think you all know what is delta hypertension. This is not new because last Williams also we read the delta hypertension. So delta hypertension is a normotensive patient going into eclampsia or end organ damage. Normotensive patient going into eclampsia or end organ damage. So normotensive patient having eclampsia or end organ damage due to rise in the mean arterial pressure. Due to rise in the mean arterial pressure. So only thing which is changed or I felt it's new which you have to remember is we used to call it as mild preeclampsia and severe preeclampsia. No, instead of telling mild, they have just changed the names to non-severe and severe preeclampsia. So you have to call it as non-severe and severe. Even gestational hypertension, he has given the new terminology as transient hypertension because it's going to stay for only for some time. The new can be referred as transient hypertension. Similarly, mild preeclampsia ka naam they have given it as non-severe. Severe ka preeclampsia severe name only. Apart from that, nothing else has changed. All these are there previously also. Here also same. So all the end organ damage signs are present in the severe, absent in the non-severe. That's all, right? So the other thing which has been included new in the Williams is prompt delivery after maternal stabilization, and before delivery you have to give single course of steroid for lung maturation. So when any of these were there previously, we used to go for immediate delivery. But now he's telling that just before delivery, give one dose of steroid so that some benefit will be there. So prompt delivery after stabilization and after single dose of steroid. So uncontrolled severe hypertension, persistent headaches and refractory to treatment, persistent epigastric pains, eclampsia, HELP syndrome, pulmonary edema, abruptio, DIC, stroke, myocardial infarction and fetal non-reassuring fetal status. So when you have any of these, you have to go for immediate delivery. But before delivery, just give one dose of steroid. That is something new. Okay? And the next thing which he has mentioned is delay the delivery for 48 hours if possible to allow the corticosteroid therapy for lung maturation. So PROM, IUGR, oligo, reverse end diastolic Doppler. So reverse end diastolic Doppler, please remember guys, the timing of delivery should be 30 to 32 weeks. So even if they cross the 32 to 32 weeks, give them 2 doses of steroids and then deliver. Okay, and worsening renal dysfunction. So reverse may also give 2 doses of steroids and then deliver, right? So this is something new. So and reverse and diastolic terminate around 30 to 32 weeks after giving 2 doses of steroids. After 32 weeks also give 2 doses of steroids and then terminate. Only for severe preeclampsia you require to admit and treat her. Otherwise you can treat her in the OPD basis. So severe preeclampsia, admit to labor and delivery room, maternal and fetal assessment, consider magnesium sulfate, treat dangerous hypertension. When there is severe preeclampsia, the timing of delivery is 34 weeks, right? So contraindication for conservative management is when they have persistent symptoms of severe hypertension, when they have eclampsia or pulmonary edema or HELP syndrome, when there is significant renal dysfunction or coagulopathy, abruption, pre-viable fetus and fetal compromise. If any of these are present, deliver her immediately. But before delivery, remember to give one dose of steroid, right? If all of those are absent, give her steroids, frequent evaluation, daily lab evaluation for help. So inpatient management may assess the mother, serial lab investigation for help and renal function, daily fetal assessment and evaluation for growth and amniotic fluid volume. So you have to do all this while you are doing the expectant management, and once if she develops complication, deliver her. If no complication, try to pull her till 34 weeks, and beyond 34 weeks you can deliver her, right? So these are the few things, like not major updates, but this one, single dose of steroid before delivery, is something new. So these are all the updates which we have in the Williams Obstetrics, guys. So these are the possible updates which are important for you and which you all should know. So that finishes the updates of obstetrics, right? So thank you guys, all the best, keep studying. Any further doubts, please feel free to ask.